Well, hello, it's Jason Renaud with the Alternative Mobile Services Association. I'm here with Ryan Mattson with the Connections and the Gallatin County Mobile Crisis team. Welcome, Ryan.
Thank you for having me.
We want to talk to you about what's going on in Bozeman, but let's start with you. Tell us a little bit about you and how you got in this line of work.
Sure, absolutely. So I am a licensed clinical professional counselor. And in the state of Montana, I'm also a certified mental health professional person, which allows for me to do the involuntary side of things here. I first got started in crisis work in Colorado. I worked at a crisis receiving and stabilization and call center, and then actually transitioned into being a co-responder with law enforcement in a pilot program in Larimer County, Colorado. And when I moved here to Montana full time, I brought that model with me and started a co-responder program with Gallatin County in 2019. And then that's transitioned now into what Connections is operating as a mobile crisis team here, which we started uh, back in, I believe, 2022.
Gallatin County is Bozeman, Montana. Tell us about Bozeman.
So Bozeman and the surrounding Gallatin County is a real interesting area. My family has been here ranching and farming for a long time, homesteading a location just north of town. So I've got to see a lot of changes that have happened within the community. And so historically, a lot of ranching and farming, and it's kind of had a recent boom here where it's drastically changing in terms of what our population is like. Our county is pretty massive. It's 120 miles north to south. And so we have a large space that we have to cover. We have real booming communities. So in Bozeman, we have Montana State University, which brings a lot of new people in. There's a lot of growing opportunities here. And then we also have real small communities up in the mountains. And so we have Big Sky. And then further beyond that, we have West Yellowstone, which can take a good couple hours to get to driving through the mountain passes. And so we have a real diverse community, which then can also be challenging at times to serve just because of the distance that we have to drive and try to reach people. We also have a lack of services. So we actually don't have our own behavioral health inpatient services here. We're kind of stuck in the middle between the two communities of Billings and Helena, which are our closest ones that have an inpatient facility. And those take each about 2 hours to get to. So we're right in the middle between those two.
So do you have a crisis center or someplace people can be for a short while?
We actually don't. We used to have a crisis facility here, which was called Hope House, which was run by Western Montana Mental Health Center, but that actually closed down years ago. And so we actually don't even have a community mental health agency here. And so all the behavioral health needs are either being handled by private practice or by our local community health partners. There are FQHC, and so they manage some of the behavioral health pieces just because no one else is here managing that, but most of it is private practice.
You mentioned that you are authorized to do an involuntary hold. Do you take people to a local hospital?
So the involuntary process with Montana is one of the more complicated ones I've heard of. And so for us in community, if we're going to do that, we have to get a medical screening on them so that we can make sure that there's nothing else going on medically that might be contributing to the behaviors. And then beyond that, once we have that, then I can petition our county attorney to then start the process, which then goes through a judge and multiple hearings and everything. But because we don't have a location to hold those individuals, we actually have to utilize the state hospital, which is past Butte. So it's about a good hour and a half drive to the state hospital if we have an individual that's going on an involuntary basis.
Very high criteria. It sounds like that's probably a last resort.
We really try for it, and it's actually led us to, we just started a brand new program through a SAMHSA grant called Assisted Outpatient Treatment, which the goal is to divert individuals away from the state hospital. And so that just started Monday with our staff members. So we're really excited to see what that might be able to do to divert those individuals away from that higher level of care.
Well, that's great to hear. My memory is that the unofficial motto of Montana is mind your own business. So I imagine that a lot of the people you encounter are pretty independent and autonomous and aren't interested in your help.
It really kind of depends. There is a sense of mind your own business, but we also have a strong sense of community and neighbors and the way that we do assist each other. And so when you are a part of that community and people recognize you as such, that it does tend to open up doors. We do have some smaller communities that actually don't even have cell phone coverage, internet, anything like that. And those communities tend to be a little more isolated and don't really want us involved in anything. But I would say the vast majority of people we work with are actually appreciative of the assistance and are happy to engage with us. And like I said, the community is drastically changing very quickly.
So tell me about the operations of your team. How does it work?
Sure. So we run a two-person team, 12 hours a day, 7 days a week. And so our hours go from 10 a.m. to 10 p.m. And so we have a therapist, and then we also have what we refer to as a mobile responder, which is a paraprofessional. And so because of our population, it can sometimes be difficult to even have peers. And so we had to kind of broaden the scope a little bit and just have paraprofessionals. And so if we have a peer, great. But if not, then we're able to take professionals from other agencies who have just kind of that experience in a crisis like role. So the two-person team responds together, they don't separate. And that way they can not only for safety, but also just managing of resources. One person can be documenting or managing incoming requests for service, while the other person is engaging with the individual who's in crisis. It could also be that maybe the other person's talking with family members, friends, trying to gather resources as we're putting all these pieces together.
That's great to hear. They're able to get from one side of the county, this 120-mile distance. How did you figure out how to locate your services?
Sure. So going back to when Connections first was asked to take on the mobile crisis team, we worked with our 911 and law enforcement partners to pull all of their data with their points of location where they were responding to different call types. And we actually did a heat map, which showed us where the concentration of calls were happening.
Hmm.
And so obviously you'll see little pockets where the communities are, and obviously more in the city, like Bozeman, Belgrade, than the surrounding areas. But this allowed us to know, okay, we need to have the team in this general area so that they're going to be able to respond as quickly as possible because we do have such a large area to cover. And actually, we had pulled this last summer as we were preparing for some presentations and found that on average, our response time is actually under 12 minutes. And that's including all those calls where we're traveling up the canyon to Big Sky, which can take about an hour. And so when we averaged them all out, it was actually under 12 minutes because we have a process that our team engages in, which we refer to as proactive staging. And so our team has access to what's called the CAD, the computer assisted dispatch.
Mhm.
And so when a person calls into 911, we can see that call happening in real time. And so my team manages that and watches all those calls coming in. And so when we see a call type that appears like it could be something for our team, they'll look at the notes on it to see, okay, is there a person who's reporting they're a danger to themselves? Is there concern for safety? Is it maybe that they're unable to meet their basic needs? If they start seeing some of those buzzwords that we pay attention to, then they will actually respond to that call and stage for it, maybe a block or so down until law enforcement or other first responders are able to arrive on scene and make sure that it's appropriate for us to be there. But
Mhm.
once the scene is cleared for us, it's actually almost a 0 minute wait time on a lot of those calls because we're already there waiting for them.
That's great to hear. Can you tell me what sort of CAD program you're using?
So the county and the surrounding partners use Zerker.
Say that again, please.
Zerker.
Zerker. Okay. Okay. This is always a question of, you know, what 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 software people are using. Uh, Talk to me a little bit about Connections. You're actually an employee of Connections, is that right?
Yes, so I work for Connections Health Solutions, which is primarily based out of Arizona. That's where it was founded back in, I believe, 2009. And so there, the individuals who started that were the pioneers of the observation model of they started it in Texas and then went to Arizona, started up connections, and then they have a location in Phoenix and Tucson. And so their bread and butter has always been the crisis receiving stabilization, those pieces of it. And so Montana was actually their first attempt with a mobile team.
Mhm.
And so we were the first location outside of Arizona as well. Now we have locations in Kirkland, Washington, Chantilly, Virginia, Harrisburg, Pennsylvania, and there's other locations that are in process of opening now. But we were the first one outside of Arizona.
That's great to hear. Was there a reason that they picked Bozeman?
I feel like Bozeman might have picked them a little bit.
Mm,
Of At that time, I was actually working at a hospital, and we were in the process of trying to develop crisis services at a hospital level.
mm.
And my supervisor actually found connections through research, and that they had essentially were the experts in the model that we were trying to create there at the hospital, a 23-hour observation model. And so she reached out to them and asked them if they'd be willing to come up and consult with us to help guide us to make sure that we knew what we were doing and starting this new program. And then just through them coming up to the community and starting to engage with the county and other partners, they realized some potential for trying their model at a more rural level. Um, we're still in the process of trying to figure out all the pieces to hopefully have our own crisis stabilization facility here in Gallatin County. So for right now, we have the mobile team, which they were asked to take on. It wasn't their goal to start a mobile team, but they were asked, and they said, "Sure, we'll give it a try." And then I joined them shortly after.
And one of the things that really attracted me to your program was your data dashboard. You have it right on your website showing everyone what, your outcomes are. Can you walk us through that a little bit?
Sure, absolutely. So our data has been one of our key pieces as a program that has really helped not only strengthen us, but help us to improve our outcomes. And so it actually initially started with just me using an Excel spreadsheet and putting some simple formulas in to pull data into a totals page. And then from there, growing into other programs, we actually we have a partner with JG Research where we report our data to them and they enter it into their dashboard, which then not only does the heat mapping process, but then also is able to break out all of our totals, calls for service, our different dispositions, and then they're able to share that with the county at the county level and state.
So you have some immediate accountability to your county commissioners. You can tell them exactly what you're doing at any moment in time.
Yes, so every month I send off our raw data to JG and provide them that information, and they enter it into their system. I also send out my monthly reports. And then we also have our own internal programs, which we use so that we have real time data collection based directly out of our EHR. So we're in the process of transitioning away from my Excel spreadsheet and moving more towards the Tableau, which allows for us to collect the data directly from our EHR. So instead of staff having to duplicate
Mm.
their efforts and enter it into an Excel, it comes directly from their notes and the information that they're putting in based on their contacts with clients in the field.
Yeah, you got your field mapping sorted out. That's great. And this JG Research, they also provide dashboards for the other Montana teams in Missoula, Kalispell, and Helena, as you tell me.
Yeah, so JG is contracted with the state to provide those support services for all the teams in areas that are trying to develop teams. So they're a real great partner in terms of not only reporting the data out, but also of developing the data and trying to figure out what are you trying to look at and what are you getting. A real quick story and example of that is last year when I was working with one of our law enforcement partners in the sheriff's office. We were looking to see what has been the change, and we were hoping to find a change in the amount of time officers and deputies are spending on behavioral health calls since the mobile team started. And when we first pulled the data, it came back that on average, they were spending 5 minutes more on a call. And so when we went back to our partners with JG and really started to dig into it, we actually were able to tease out and find that that's not actually what was happening. The call length was taking that time, but officers were no longer on that call. Our team, which is referred to as
Uh,
GMC, Gallatin Mobile Crisis, was still there. And so that's why it's been really helpful and why it's so important to make sure that you know what your data is telling you, because we don't want to go back to the commission and say we're actually causing you to spend 5 more minutes on average, when in reality over the 2 years we had a 70% reduction in the amount of time that law enforcement is spending on behavioral health calls.
so you've told us you're an LCSW, but now you've revealed you're a true data nerd as well.
Well, LCPC, I don't want to claim to be the
Sorry,
social worker. So
say,
yes,
say that again for me.
I'm an LCPC. So I'm a licensed clinical professional counselor. So
I see.
yeah, so everywhere else I'm an LPC, but here in Montana, they like to throw in that extra letter.
On your dashboard, there's two call types that are mentioned, welfare check and suicide threat. Um, those are the top call codes. What other sorts of call codes do you go out on?
So we have specific call types that are built into the system. Those are referred to as run cards. And
Mhm.
so there are run cards which include the welfare check, the suicidal individual, where we're automatically dispatched. But really, in terms of call types, we've gone on everything of, from trespassing to we've had car accidents. We've had situations where people have essentially hold up on their property, and the negotiators are working with them, trying to figure out a plan. And they've communicated with us some on how we can try to engage with that person peacefully. So there really isn't a specific one type. And anytime anyone asks me, when should they call us? My response is always, if there's a person involved, we probably should be there. Because even if it's a medical situation of, say, someone has a heart attack and they're rushed off to the hospital, they may be leaving family members and others behind who may go into crisis. And so there really is an opportunity for mobile teams to go well beyond what we typically view as behavioral health, with the suicidal, the unable to meet basic needs due to their mental health, and really engage people with that self-defined crisis.
That this is something I think is true in rural and small city teams, is that they have a much wider bandwidth for different kinds of events, and that's something you can certainly teach the big cities.
Mm-hmm. I think that our goal is to divert away from that full-blown emergency, right? So all of us go have moments where we go into crisis, and some of us may be able to better address those on our own without outside resources. But it could be any kind of struggle, and hopefully we intervene at that point before it escalates. And I often say this is one of the few jobs where our goal is to put ourselves out of business. Of we want to be meeting with people before it gets to that full-blown crisis, so that hopefully, they don't lose work when if they potentially have to go to a higher level of care, or the financial burden of having to go to a hospital, or of those other pieces. And so really trying to meet with people as close to the event as possible, and not allow things to build and let things get out of control.
No, that's great. You got it, Ryan. Thank you so much for talking to me, telling me about your team and Bozeman, Gallatin County connections. Great work.
Absolutely. And thank you so much.